Hello, my name is Capone Jr. I'm a professor of ophthalmology at Oakland University in Michigan, in the United States, and I'm also a member of a retina group known as Associated Retinal Consultants, also in Michigan. The topic for today is anti-VEGF therapy for retinopathy of prematurity. This is a topic that has had significant interest in the last 5 to 10 years. And relatively recently, a study known as the Rainbow study was completed, which was sponsored by Novartis, a prospective randomized trial looking at 2 different doses of ranibizumab versus laser for treatment of retinopathy of prematurity. The conventional treatment for ROP has been peripheral retinal ablation, in the old days done with cryo, and more recently, of course, done with laser. The advantages of this therapy is that it was very meticulously studied in clinical trials, so we know a lot about it, both when it works, and it generally works quite well as when it doesn't work. So the treatment outcomes, positive and negative, are very familiar to everybody who takes care of children. Anti-VEGF therapy offers a very powerful new tool, relatively new tool for the treatment of ROP, but the problem has been the unpredictability with regard to what I refer to as the back end of treatment. After the ROP regresses, do you need to retreat? When do you retreat? How do the eyes do with regard to when they do well, and how do they do when they do poorly? Again, very clearly understood and carefully studied for laser, not really until recently as clearly understood or well studied for pharmacotherapy with anti-VEGF agents. So for example, once you treat an eye with laser and the eye is effectively treated, the eye may do well or not do well, but typically does not need more laser. An eye that's treated with an anti-VEGF agent, up to 97% of these eyes have persistent avascularity of the peripheral retina. This was reported by Darius Mushfeghi in the American Journal of Ophthalmology at the end of 2018. We also know that children can have recurrent ROP activity out to 2 years or more after their injections. So if you have persistent avascular retina and the risk of reactivation can extend out to 2 years, how are these children to be followed? Do you see them once a week until they vascularize? Do you see them once every 2 weeks? Do you see them until they're 2 years old? Because everyone who takes care of these children knows that once they get above 12 pounds or so, maybe 5 to 6 kilos, they become much more difficult to examine in the office, and we can't practically put them to sleep to examine them all the time. So all of these issues really kind of remain to be clarified with regard to anti-VEGF therapy. The other thing about anti-VEGF therapy is the children who do go on to a retinal detachment, those who fail anti-VEGF therapy, tend to develop detachments that are unique in terms of both their appearance and their time course of development. Just like the treatment response post-laser, which they either do well or don't do well within 2 months of treatment, children with retinal detachment following pharmacotherapy can either develop can develop detachments that are not typical. Some are atypically quick. About 10% of children will develop detachments within a week. There are other children who will not develop attachments beyond 10 weeks or longer, as I mentioned, out to 2 years after treatment. So number one, they're different with regards to timing compared to laser, and they're also different with regard to anatomy. The ones that are treated with drug, with anti-VEGFs, tend to develop either a circumferential contraction in the mid-periphery of the retina, or, and this is a detachment that is very unique to drug therapy, they will develop a detachment that is centered right over the optic nerve. Interesting because detachment usually occurs due to contraction of neovascularization generally. These detachments that are due to contraction over the nerve have no neovascularization associated with them, so it's just hyaloidal contraction over the optic nerve. These detachments, though, can also be treated surgically. They tend to very commonly be bilateral and have a fairly typical appearance. So anti-VEGF therapy is a powerful new tool for the treatment of retinopathy of prematurity. Many children do very well. It is easier to do than laser on a sick child, and is certainly easier on the child. However, there are some unique characteristics with regard to following the children up post-therapy, and there are some unique characteristics with regard to the timing and anatomy of retinal detachment that can occur following treatment. So to date, the only drug studied in a large clinical trial has been ranibizumab, studied in the Rainbow study. There have been a number of small non-prospective series or small center-based series, but as a relatively large study with over 100 children, the Rainbow study certainly is the only pharmacotherapy study to date of that size and that kind of epidemiologic impact. Bevacizumab has also been studied, but in a smaller clinical trial, and there is in the works a prospective clinical trial planned evaluating aflibercept for the pharmacotherapy of retinopathy of prematurity.